Welcome to our July AIDS Clinical Conference. Thank you so much for joining on this beautiful spring day, the last days of spring before the summer. We have Dr. Jehan Budak, who many of you know through the ECHO community and Mountain West AETC, as well as the National HIV Curriculum. Dr. Budak is the Assistant Medical Director here at Madison Clinic, but has other hats. She's the Associate Editor of the National HIV Curriculum and is active in resident and student education. She's the HIV Pathway Director for Training in Internal Medicine here at University of Washington as well. She's going to be talking about long-acting injectables for treatment of HIV. She happens to be the medical director of the Injectables program within our clinic and is very good at ART stewardship. And I will let her talk and stop talking now. Thanks, Jehan.
Thank you, Shirisha. Well, good morning, everybody. As Shirisha mentioned, I'm going to be talking about long-acting injectables for the treatment of HIV. I have no disclosures, and my objectives for today are to describe, and for you all after this, is to describe long-acting injectable treatment options for people with HIV, including options for individuals not virally suppressed on oral medications, mostly focusing on cabotegravir and rilpivirine, and unfortunately not doing lenacapavir a lot of justice with just a couple of slides about it at the end. And then my other objective is, my hope is that after this to be able to incorporate data on long-acting injectable treatment options in your decision-making regarding its use or implementation. So let's get started with CAB-RIL. We're going to go through this just with some background data. Then I'll talk a bit about virologic failure with CAB-RIL, some clinical review considerations, use in persons with viremia or adherence difficulties, and then a bit about implementation and logistics, and then we'll switch on to lenacapavir. And I could obviously talk for an hour about each of these bullet points, so my hope is that we can just move through these relatively quickly, and I have picked some things to go into a deep dive on and others not so much. So we'll see how this goes. So background data. To take a step back, I think we all are aware that these are the currently FDA-approved 2 drug regimens for ART. For initial therapy, we have dolutegravir and lamivudine. And for maintenance therapy, we have dolutegravir, lamivudine as well, dolutegravir, rilpivirine, and cab-rilpivirine. And I wanted to show this slide just so that everyone's aware that currently its only FDA approval is for maintenance therapy. Here's another way to look at that, the FDA-approved 2 drug regimens, with the first one being a combination of an INSTI plus an NRTI, and then the latter 2 being a combination of an integrase strand transfer inhibitor and an NNRTI. And obviously, we're going to be focusing on CAB-RIL. So a bit of background before we dive into some of these studies. The Atlas FLAIR and Atlas 2M studies demonstrated efficacy of cab-rilpivirine. These were at least Atlas and FLAIR were the initial registrational trials that led to FDA approval for virally suppressed people with HIV. Then we got Latitude, which was another sort of randomized trial in persons with adherence difficulties, and they found that the injectable CAB-RIL Q4 weeks was superior to oral standard of care. The Drug and Safety Monitoring Board halted randomization and offered switch to cab-rilpivirine for all patients. And then the CARES study of injectable CAB-RIL every 8 weeks, administered in public health settings in sub-Saharan Africa, showed or was non-inferior in virologic efficacy to oral standard of care and was well tolerated. So I think for me, these are some of the big studies. There's many other studies, and I apologize if I did not include all of those. And we're going to take a little bit of a deeper dive as I sort of go through the chronology of all of this here as we go. So first, let's start off with Atlas. This slide is from Dr. Brian Wood, talking about the study, which is, again, a randomized open-label trial comparing IM-CAB plus IM-RIL after oral induction for adults taking a 3-drug oral ART regimen. So this is Atlas, which was used for switch. It was a switch study. As you can see, these are the inclusion criteria. People had to be suppressed for at least 6 months, and no history of virologic failure, and no INSTI or NNRTI resistance mutations allowed except for the K103N. And here on the right, you can see that people were randomized to oral CAB-RIL with a lead-in, followed by IM CAB-RIL every 4 weeks, or to continue their 3-drug oral regimen. And as you all know, hopefully, is that it was shown to be non-inferior. Now, then there was the Atlas 2M study, which was, I like the name because 2M every 2 months. And so they compared Cabril every 8 weeks versus every 4 weeks. Very similar inclusion criteria. Again, sort of taking an uninterrupted first or second oral standard of care ART regimen for greater than 6 months and having viral suppression, and randomized either to every 8 weeks injections or every 4 weeks injections. And as you can see here on the right, that the dosing for every 8 week injections is different as compared and higher as compared to the every 4 week dosing. In addition, it's a higher volume that is being given as well. And so here, as we all know, the Atlas 2M study showed that it was non-inferior to every 4 weeks versus every 8 weeks. I will skip flare and move on to say that sort of at that point, after FDA approval, the HHS, or the Department of Health and Human Services, recommended Cabril monthly or every 2 months that can be used to replace an existing oral ARV regimen in people with HIV with sustained viral suppression for 3 to 6 months. So this is what the HHS is recommending based on this data. Their criteria for use, with or without an oral lead-in, because in this time frame, it sort of became clear that the oral lead-in could be optional, included a history of good adherence and engagement in care, no baseline resistance to either medication, no prior virologic failure, no active or occult Hep B infection unless already receiving Hep B active meds, and no drug-drug interactions with oral or injectable CAB or RIL. So that was kind of the state of things in November 2023. Some of you may have also seen that at those times, there was recommendations to not give it for people who had adherence difficulties or who were viremic. So that was kind of the state of things then. Now, I'll come back to people with adherence difficulties and with viremia, as you can tell on this outline, but I want to take a quick aside and talk about virologic failure. So that was the data that showed it's efficacious, it's non-inferior. Let's talk a little bit about who are the people that fail on this and what happens. And I'm going to just dive right in to the risk factors for virologic failure. So Cottrell in 2022, followed by then Chloe Orkin with Cottrell as Amy Cottrell as the senior author in 2023, took pooled data from 1,600 participants in Atlas, Flare, and the Atlas 2M studies. And overall confirmed virologic failure rates were 1.4%. And so they saw this in 23 people with HIV, and that was through 152 weeks. And this, as I mentioned, the original study was by Cottrell, smaller number, not as long of duration. And then in 2023, they redid this with more people and through 152 weeks. They explored dosing, demographic, viral, and pharmacokinetic covariates to see which sort of variables or factors were associated with virologic failure. And they found that having greater than or equal to 2 of the below factors was associated with increased virologic failure or with increased viral failure risk. So first was rilpivirine resistance associated mutations. Second was having an A6 or A1 subtype. And then last was having a body mass index of greater than or equal to 30. Now, my understanding was that if you had if you had 2 or more, that you actually have, even a 20% higher risk of failure. So it's not a negligible amount. And so this is very important information as we are sort of thinking about who is a candidate for Cabril. Now, I want to next share, I already mentioned the CARES study, but I want to sort of tie this in here because it was a big deal in 2024 and 2025 when it was presented at CROI. And it was a randomized open label active controlled non-inferiority study of people in sub-Saharan Africa, in Uganda, Kenya, and Tanzania. And there are about 250 people each in each arm, randomized to oral standard of care versus Cabril every 8 weeks with an optional oral lead-in. As you can see on the left in the gray, inclusion criteria were that they had to be adults on a stable regimen with a viral suppression at least 4 to 12 months prior to and at screening, no history of renal failure, and no Hep B infection. So here is a cohort of individuals in sub-Saharan Africa who are coming in virally suppressed on meds, but no genotypes at baseline that were seen, placed on Q8-week Cabril, with a viral load checked every 24 weeks. So a lot more, or a lot less frequent than we're checking here. And so due to a public health approach to enrollment, as I kind of intimated, resistance analysis was performed during therapy, and proviral DNA was performed for archived resistance on stored PBMCs. So very much a real world study design. And great news is that both at week 48 and week 96, long-acting Cabril demonstrated non-inferior virologic efficacy as compared to oral standard of care. This is the first time I'm mentioning injection site reactions. We're going to talk about it later. 77% of people had injection site reactions, very consistent with prior studies. Over 99% on Cabril preferred injectable to daily oral therapy. There were 4 cases of virologic failure, 1.6%, similar to other confirmed virologic failure rates that I've mentioned on prior slides. And then here's the real big thing, is that of note, 55 participants in the CARE study had subtype A1 virus. Now, that's a big deal because just 3 slides ago, I had shown that the second, one of the 3 risk factors for virologic failure was having subtype A6A1 virus. And so here in the CARE study, it shows that, hey, here's half of people who have a subtype A1 virus. Clearly it's okay. And so now, as you might notice, this is the same slide I just showed you, but it's been modified, and I modified it to get rid of A1 subtype. And so now we feel that it's really just a 6 subtype that is one of the 2 below factors. And it's really, for me, that I think that the CARES data that is helpful amongst other things. So that is one aspect of virologic failure. What else is known about virologic failure with long-acting Cabril? So it typically occurs in the first year. They're in the Chloe Orkin paper where they actually sort of pooled the 1,600 participants. The median time to suspected virologic failure was 24.9 weeks, with a range of 16.9 to 49.3 weeks. So typically we're going to see this in the first year. And so I think that's why I suspect many of us are checking viral loads more frequently in that first year, especially since 1, we know that the person is not yet at steady state. It takes about 44 weeks to get to steady state with the medication. And 2, because we know virologic failure, if it's going to occur, typically occurs in the first year. The other thing we know about virologic failure is that failure, despite perfect adherence, has been seen. And so at CROI in 2023, they shared the SOLAR study, which was a randomized controlled study of 670 stable or people with HIV, virally suppressed on BIC/TAF FTC, switched to Cabril every 8 weeks, comparing that to continuing BIC/TAF FTC. And luckily, viral suppression was non-inferior at 12 months. So we know that. But 3 individuals had confirmed virologic failure in the Cabril arm despite on-time injections, and there was no confirmed virologic failure in the BIC/TAF FTC arm. So although this was presented at CROI, it was then published, and here are the numbers from that. And so I recall that at CROI, during the Q&A session, that actually Laura Waters from England came up to the mic and said, so essentially, and I'm sort of paraphrasing, she essentially was like, so to be clear, people on Cabril with perfect on-time injections had failure. The people with their perfect on-time BIC/TAF FTC did not. And they were like, yes, that is correct. And so after that, I incorporated counseling patients saying, hey, like, just so you're aware, there have been failures despite perfect adherence, despite doing everything that you can. Now that has been in the Q8 week arm. I don't have a comparator for Q4 weeks, so we don't know if that has been the case, but there are some things that I think are a bit, that remain a bit unknown, whereas with BIC/TAF FTC or other oral ART, if someone's taking it every day, it seems that we have not seen, or, it's rare that you would have failure, whereas we have seen that with Cabril. So that's something, again, in the back of my mind and something that I counsel patients about, especially when I'm talking to someone who is already virally suppressed, doing well on their oral ART and seeking to switch. So that's one type of individual, right, who's coming to us sort of doing well on their oral ART, seeking to switch. That's not the sort of viremic individual or the person who's having difficulty with adherence. So that's some things about virologic failure. Matt Hickey and the group at Ward 86 sort of talked about or have done a lot of work with regards to injectable Cabril. And they sort of posit 2 different categories of virologic failure. One is early failure despite on-time injections, which I kind of was talking about on the prior slide. And then there's late failure due to late injections, personal choice not to resume oral ART, or loss to follow-up. And I liked this quote in their paper that said that sort of they're sort of recognizing the complexity of a long-acting injectable treatment in which the unique circumstances of a patient's care trajectory require nuanced decision-making. So my hope is that throughout this that you'll pick up some of these nuances and carry them forward. A little bit about virologic failures there. Now let's move on to clinical review considerations. And I specifically wanted to talk about virologic failure before we talk about how sort of some of us here think about Cabril, because I always want people to be thinking about what are those virologic failures that could be happening in the back of your mind when thinking about an individual. And so here's a case to sort of illustrate and take us through how we typically will think about this. So a 45-year-old man with HIV is suppressed on Big TAF FTC. His last CD4 cell count was 476, and his last viral load was undetectable. His viral load has been undetectable for several years. In general, he has good adherence, but does shift work as a firefighter and has difficulty at times with taking his ART when he's on those shifts. He finds this to be stressful, understandably, and he does not like to bring his medication to his shift. And his PCP places a referral for injectable Cabril. So here is an example of someone who's interested in Cabril. Well, on the next slide, I will sort of take us through the things that we're thinking about. And I think this really middle paragraph I wanted to highlight here because it's really helpful to know why someone's interested in Cabril. It's, because oftentimes we'll have to sort of be looking at the eligibility, making decisions regarding that eligibility, having shared decision-making with the patient. And it's, again, helpful to know what is it. And in this case, he's doing well on his orals. However, there are some issues, especially when he's working his shifts. So here are the things that we typically consider here in clinic at Madison as far as eligibility review. We talk about CD4 and viral history, or this is what we're looking at. Mostly our clinical pharmacists are doing this. ART history, including current ART. Drug resistance history, including subtype. Clinic visit and ART prescription history. Drug-drug interactions. BMI. Pregnancy status, and their Hep B status. And this is, again, all with these potential 3 viral failure risk factors. And so basically, I know that I am referencing Chloe Orkin's paper throughout this. However, this is, again, Amy Cottrell is the senior author. This is all built on the initial Cottrell paper. So if I at any point say, based on the Cottrell risk factors, that's what I'm referring to. So let's take this man. As far as his CD4 and viral load history, I can sort of let you know that CD4s have always been sort of in the 400 to 500 range, and his viral loads have always been undetectable. Since he was diagnosed, he was placed on ART immediately, had viral suppression, was previously, for the past was initially diagnosed in about 2014, placed on abacavir 3-TC dolutegravir, and then, as mentioned, switched to Big TAF FTC. So that's his ART history. As far as drug resistance history, he is, we have a genotype at baseline from when he was diagnosed, is subtype B, and he has wild type virus, and so no RT or PI mutations, but we don't have an INSTI genotype from that time. Clinic visit and ART prescription history. So this is important. One, the clinic visits we're kind of using as a litmus test to see, can the patient come in? If someone always picks up their meds, is always virally suppressed, but never comes to clinic, that might be a person for whom coming in once a month or once every 2 months may be difficult. And I think I don't want us to sort of minimize the sort of lift that it takes to come to clinic, driving, parking, taking the bus, et cetera, getting a ride, right? People have so many different sort of modes of transportation. And I think it's not negligible to come to clinic. So we're looking at clinic visit history. We're looking also at ART prescription history and their pickups. Are they picking up their meds? Are they someone that we're thinking about who is doing very well on their oral regimen and whom we should sort of take a conservative approach with eligibility criteria? Or is it someone who's not doing well with their ART prescriptions, and in whom we can be a little bit more liberal in our approach, since clearly orals aren't working as well as perhaps an injectable might. We take a peek at drug-drug interactions. He has no other medications, so has no DDI that we need to worry about. His BMI is 29. He's not pregnant, and he is Hep B immune. And I'm going to talk about a little bit more of these in some detail in the next few slides. So oftentimes when we're looking at the eligibility review, we use the Ward 86 injectable guidelines. It's many pages. It's available on the Getting to Zero SF website. This is now, I believe, the third iteration. There was a 2023 and I think a 2022 guideline, and it changes. And so I do recommend taking a peek at these and using them. They're so helpful and so thorough and detailed. So this is a bit of a background as to sort of what are we using as well, in addition, when we're making these eligibility decisions. Here is a screenshot from there, and I'm going to read this section because this is about the sort of the decision-making regarding resistance. So patients with virus with any NNRTI mutations or INSTI mutations that could compromise either rilpivirine or CAB in past genotypes should not be started on the long-acting regimen. We have decided on the mutations, which we will exclude, based on which rilpivirine or CAB resistance mutations were associated with breakthrough infections in FLAIR, ATLAS, or ATLAS 2M, which we've talked about, HP2N 083, the study which was examining every 8-week IM CAB for HIV prevention or PrEP, and the ECHO-THRIVE trials, which were the initial registrational trials studying rilpivirine compared to efavirenz for first-line therapy in treatment-naive patients. Here is the list of the rilpivirine RAMs, or resistance-associated mutations, that they find to be exclusionary. Here are the cabotegravir RAMs that they find to be exclusionary. I share this because we were just talking about this yesterday. This has changed with every iteration of the Ward 86 guidelines. And as we learn more information, some mutations are dropped and new mutations are added. In addition, some polymorphisms are dropped and some polymorphisms are added. And so it does take a lot of effort to make sure that the person doesn't have either a polymorphism that could increase their potential risk of failure, or a mutation that would increase their risk of failure. And so that is something, that's why I've titled this slide polymorphism or RAM. Now, the L74I is now a major mutation in subtype A6. And this is, I share this one because it's important information, but two, just to highlight how the landscape has changed. Remember, these are new meds. And so we're learning a lot on a day-to-day, week-to-week, and month-to-month basis. So of the 6 virologic failures from the ATLAS and FLAIR registrational trials, 5 had an L74I integrase mutation polymorphism. All 5 people with HIV with virologic failure. So again, 5 of the 6 people who failed had an L74I. All of those with the L74I had a subtype A1 virus. Now, at that time, it was felt that the L74I was an INSTI polymorphism. And then in March 2025, so just 3 months ago, IAS USA updated their guidelines and wrote that L74I, a signature mutation in HIV-1 subtype A6 that may occur as a polymorphism in other HIV-1 subtypes, was associated with confirmed virologic failure in clinical trials of long-acting CAB and rilpivirine. And so in March 2025, they updated their IAS USA little pocket guide for mutations to include that an L74I in subtype A6, hence here's a little a, relevant for subtype A6 only, is a major mutation with regards to cabotegravir. So polymorphism or RAM. Now, what about proviral DNA genotype resistance? So I think we hopefully know that proviral DNA resistance testing has high specificity but low sensitivity. And at UW, from 2015 to August 2024, 61% of proviral DNA testing was sent between 2023 to 2024. So by that, I mean, I personally used to never send proviral DNA resistance testing. Maybe I sent a proviral genotype once before CAB-RIL came out. And then I have been sending it a lot more now. And hopefully I'm not the only person that is causing this uptick at UW Medicine. I know others are as well, but I just wanted to highlight that at UW, again, over this essentially a decade, 61% of all the proviral DNA testing was done in the year and a half just prior to these numbers being pulled. So really, it seems as though the use of proviral genotype testing or an archived genotype has increased here at UW as well. So does that mean that we need it? Does that mean that it's helpful in this decision making? So we have some data from a cohort of 383 people with HIV at UCSD or at the Owen Clinic who were referred for evaluation of Cabril. And there, they sent proviral DNA resistance testing in 35% of individuals. And the way they did there is they were like, well, if you don't have a genotype, we're just going to send this. And so they did that. And in those individuals, about 20% had a RAM that led to a decision to defer Cabril. Here, we have sent proviral DNA sequencing on only 15% of people with HIV being evaluated. We have a bit more of a sort of a thoughtful process to that where we're trying to figure out, based on the number of risk factors, would this make a change? And then when we send that, we found that 52% had treatment deferred due to those results. So thoughtful, judicious use of proviral DNA testing may, in italicized, may, have a role in evaluation for long-acting Cabril. Moving on, talked about genotypes, drug-drug interactions. As a reminder, rilpivirine may prolong QTc, and drugs that induce UGT1A1 or CYP3A4 may decrease plasma concentrations of cabotegravir or rilpivirine, respectively, as cab is mostly metabolized by the UGT1A1 pathway and rilpivirine through the CYP3A4 pathway. Key classes with interactions, including contraindications in red, are as follows. The following 4 anticonvulsants, the rifamycins, being on systemic dexamethasone, more than a single dose, and St. John's wort are complete contraindications to Cabril. Interestingly, macrolide antibiotics such as azithromycin or clarithromycin may increase concentrations of rilpivirine. And then methadone, the combination based on sort of metabolism, may actually result in decreased concentrations of methadone. And similarly, too, with the macrolides and methadone, we need to sort of be, again, cognizant of potential QT prolongation. So we're still doing this clinical eligibility review. We take a peek at the drug-drug interactions, and these are some of the ones to keep in mind. Now, what about BMI and Cabril? I mentioned that that was one of the things that we're looking at. So as a reminder, BMI greater than 30 is one of the 3 risk factors for virologic failure. I think we can all agree that BMI is an extremely imperfect calculation. That is a caveat. And then we have found that in the sort of with Cabril, there is variability in pharmacokinetic parameters with higher BMIs, among other factors. For example, we know that in females, Cab has a very long tail, like a tail of up to a year. And so we know that there are some other factors, but we know specifically also that there's variability in PK with regards to higher BMIs. And unfortunately, as little is known about the impact of class 3 obesity, which is defined as a BMI greater than 40, on Cabril pharmacokinetics. And so, most of the data we have is regarding BMI greater than 30 is in the 30 to 40 range, and we just don't have that much about people who have a BMI greater than 40. Or again, what about, people have heard me say, like, what about a BMI of 60, right? That's very different than a BMI of 31. And so I think, we know that it's a potential risk factor. I believe the incidence risk ratio from the Cottrell and Orkin papers was that it was just barely above 1. And so it doesn't sort of increase the risk of virologic failure that much. There have been some studies that have shown that a higher BMI is associated with lower trough levels of CAB. And again, I mentioned already that there's variability in pharmacokinetic parameters. So I think we still don't really know, 1. 2, it is one of the 3 risk factors for virologic failure. And 3, I've bolded this at the bottom, that if you are using Cabril in a person with a BMI greater than 30, to make sure that you're using a longer 2-inch needle, as opposed to the 1.5-inch needle. Okay, the other thing that we check is is sort of pregnancy status. So little is known about the safety, efficacy, and outcomes of Cabril in pregnancy. And the HHS guidelines state, as of September, that data are not available about the efficacy and safety of injectable CAB and RIL during pregnancy. Observational data suggests efficacy, safety for the fetus, and adequate concentrations. However, its use is not currently recommended. And then there are some case reports, brief reports, and some studies looking at this, and I've included one here on the right. And I think if you do have someone who becomes pregnant while on Cabril or is on Cabril whilst during their pregnancy, I would recommend to submit it to the antiretroviral pregnancy registry. Now, I think there's a couple of things. It seems, right, that we think that it's safe for the fetus, and I think that's wonderful. And that's very important to determine. Two, I think we also need to be cognizant of the fact that we would like to prevent mother-to-child transmission, and we don't want the fetus or baby to get HIV. So weighing those risks, potentially the risks of Cabril versus the benefits. I think the other thing to keep in mind is that with oral rilpivirine, we know that there are concerns, especially in the third trimester, about the bioavailability, or at least volume of distribution, and whether or not rilpivirine is getting high enough concentrations. So those are some things that we would worry about with oral rilpivirine. What's going on with injectable rilpivirine? I think we don't know. How is a depot shot of rilpivirine how is that impacted by the volume of distribution and the changes in pregnancy, especially as one goes further along in pregnancy? And so I just think that there's a lot that we don't know. There is a patient who at Emory was treated with Cabril and lenacapavir. They placed the lenacapavir in a gravid subcutaneous abdomen. Patient did well, baby did well, baby did not get HIV, and that's that. So I think that this is uncharted territory. I think there are some things that we don't know, and I think that if here are some resources and things to sort of be aware of, but these are things that we're thinking about when we are talking about somebody's eligibility review. Okay, and then the last of the eligibility review considerations are Hep B status. So neither CAB nor rilpivirine, as a reminder, are active against hepatitis B. And unfortunately, Hep B vaccination rates among people with HIV remain low. So from a prevention standpoint, ideally, people with HIV would have Hep B immunity prior to starting CAB initiation, right? Because as we are removing a Hep B active agent, typically tenofovir, and switching them to CAB rilpivirine, they will no longer have an agent that is sort of somewhat protective against acquisition of Hep B. And also too, we just need to make sure that they are immune. So ideally, person would have a sort of positive surface antibody to Hep B prior to starting Cabril. And you can even incorporate immunization into injectable ART workflows to facilitate that. And so the group at Emory actually published their experiences where they sort of streamlined Hep B immunization in their individuals being sort of considered for Hep B or for Cabenuva, or pardon me, for Cabril injections. And then as far as treatment goes, as you might recall, the initial HHS recommendations for Cabril I mentioned said that, hey, if somebody has active Hep B, Cabril is contraindicated unless you have an active Hep B agent. And so I think we have had some patients, including a patient of Sharisha's, where the person was not taking any medication. And so we opted to use Cabril for them. And they also have chronic Hep B. And the plan is to also have them take a medication, tenofovir, for their Hep B. So I just wanted to add that especially as we're sort of having people who are, if somebody has chronic Hep B and is taking a tenofovir-based regimen already, it doesn't really make a lot of sense to switch to Cabril unless there's some other reasons. But if someone is viremic or has adherence difficulties and is not taking any medication, whether active against HIV or Hep B, and we've had these discussions with the Max Clinic as well, where, let's at least get their HIV treated, let's get them on Cabril, and we can add tenofovir to treat their Hep B. So again, you can use Cabril in chronic Hep B if it's being paired with a Hep B active agent. And I forgot, sorry, there's two other things to consider, is to do an oral lead-in or not to do an oral lead-in. So as a reminder, use of an oral lead-in is optional. The recommendation is to participate in shared decision-making with the patient. And then here we recommend it if a patient has many drug allergies or intolerances, right? The whole concept of the oral lead-in actually is that not that we really need it to get adequate concentrations. It's now really used as a sort of barometer or to help us ascertain if the patient's going to have any untoward side effects or reactions to the medication. And so it's might as well test that out with pills before giving somebody a long-acting injection of a medication that's going to stick around. If you're going to do an oral lead-in, I think you can do either the full 30 days or a week, and then they can sort of have the pills laying around if needed. And because really it's just, maybe about a week's worth of meds to make sure that the patient really had, just to check out their tolerability to it. And the one thing that I want to mention is that use of the oral lead-in is logistically difficult as it requires acquisition of oral cab and oral rill from the pharmaceutical company. Okay, other thing to keep in mind when we're doing our clinical eligibility review is like, are we going to oral lead-in or not? And then are we going to give it every 4 weeks or every 8 weeks? Most individuals are on every 8-week dosing. And in most of Europe, that's the only way that cabotegravir and rilpivirine is available, is every 8-week. I do think that we are fortunate to be able to sort of decide if someone can receive it every 4-week or every 8-week. And I think that's really important for people with adherence difficulties or who are viremic. So again, most people are on every 8-week dosing, but if someone is viremic, or has adherence difficulties, we're using every 4-week dosing. And that's because based on the Latitude study, people with HIV with adherence difficulties should be receiving injections every 4 weeks. That's all the data we have right now for that patient population. And so every 4 weeks it is. The Crown study, however, is recruiting individuals with adherence difficulties and viremia and will be administering injections every 8 weeks. So I think in the coming years, we will have answers about that and whether or not we can sort of space out the frequency of dosing for those individuals. Okay. We've evaluated that person. I've shared with you the things that I consider and that we consider, and mostly, again, our amazing clinical pharmacists here at Madison consider. And now I'd like to switch to use of Cabril in persons with viremia or adherence difficulties. Okay, so I already mentioned the Latitude study, which we'll go into a deeper dive with this, is a phase 3 prospective randomized open label trial of people with HIV with barriers to adherence who have had poor viral response despite oral ART for greater than 6 months and have been lost to follow-up with ART non-adherence for greater than 6 months. They cannot have Hep B and no INSTI or rilpivirine RAMs historically or by screening. Here, step 1, they have to be placed on a standard of care ART. They're given conditional economic incentives, and then they were randomized to Cabril in arm A every 4 weeks versus standard of care arm B, which is again just the oral. And their primary outcome was regimen failure, defined as the earliest occurrence of confirmed virologic failure or treatment discontinuation in step 2. I'm going to skip ahead to the results where the interim data was shared at CROI in 2024. And here you can see on the left, this is their primary outcome of regimen failure. But then really in these 2 boxes, the secondary outcomes of virologic failure and treatment-related failure was found that Cabril was much better and had lower rates of those sort of untoward effects. And so it was found that long-acting Cabril was superior to oral standard of care in secondary outcomes. Again, there were fewer virologic failures and fewer treatment-related failures. So in February 2024, the DSMB recommended to stop randomization and offer all eligible participants switch to Cabril. So this was very exciting because it really kind of allowed many people to sort of switch from saying like, okay, we're really just using Cabril in people who are virally suppressed to now people with adherence difficulties adherence difficulties and or viremia. So that is that aspect of the Latitude study. I wanted to also put in a plug for the National HIV Curriculum's podcast. And Dr. Brian Wood, who is the sort of lead editor for that, interviews Adia Rana, who is the first author and the person and the trial lead and the study chair at the University of Alabama. And he has an episode where he interviews her about the Latitude study. So, as I mentioned, based on that information in September 2024, the HHS panel sort of changed their recommendations and said that they recommend the use of long-acting Cabril on a case-by-case basis in select individuals with persistent virologic failure, despite intensive adherence support on oral ART, who have no evidence of resistance to Cab or Ril, and with shared decision-making between providers and people with HIV. Real-world experience among people with HIV initiating Cabril while viremic are encouraging, with greater than 90% of individuals achieving viral suppression. And we had some more of that data from CROI this year, where people are doing very well in the setting of having been initiated while viremic. So why do we think that is? This is some qualitative results from a study by Kat Christopoulos, sort of at San Francisco, in Chicago, and Atlanta, of people on injectable Cabril. And on the left, a 66-year-old man said, and also the psychological impact of it. It's like being imprisoned in a space that you can't leave. You're locked in this room and you're pulling on the door, but you can't open it. The feeling of being imprisoned. There's no way escaping this daily routine of so many pills per day. There is no freedom from it. And so this individual very much found a benefit of switching to injectable Cabril. And then similarly, this 32-year-old man in San Francisco said, I would know that I wasn't going to be able to take the medication, so I would get high before. Now that everything's better, everything's working, it's not so difficult to come here to the clinic. It's so much easier because I know my health is right. I'm happy to come in and it's a better feeling, and I don't have to be high before I come here. These are direct quotes and exactly from the paper. So all this to say, there are some really amazing benefits to taking injectable Cabril, and especially for people with adherence difficulties or with viremia. Now, what do we actually know about viral decay with Cabril? This is also from Kat, but from an earlier paper of the Ward 86 demonstration project of their initial group of people with viremia placed on injectable Cabril. And on the x-axis is days from first injection, y-axis is their viral load, and here is the key of their colors of their about 15 patients who began viremic. So these are their HIV RNA levels of persons with viremia initiating injections. You can see that there's a cohort of individuals for whom within 28 days, they become undetectable. And that is fantastic. There's another group of people in whom it takes a while. And I think this is really what we've seen, where there's some people where you're like, wow, how did you go from millions to undetectable so quickly? And then there's some people who take months to become undetectable, either hanging out in a low-level viremia sort of section, or maybe even having frank viremia and then eventually becoming undetectable. And the other thing too is that we've seen a lot more low-level viremia, these levels of like 50, 60, 70, et cetera, in people on Cabril, even even individuals who started suppressed. And so I just think that we have to, I'm becoming more comfortable with low-level viremia by use of these medications. And then on the right in the box, I've added that for 3 patients who had not yet achieved viral suppression, they wrote that all had a 2-log decline by a median of 22 days. So again, I think we're still sort of learning about the viral kinetics of Cabril, but I wanted to share this and then the following slide too, which is our graphs taken from Dr. Kate Crawford, who is a lab medicine resident here. And these are the HIV RNA levels of people with HIV with viremia at UW initiating injections through December 2024 with their results through March 2025. The red line, and these are individual patients, obviously you cannot tell who they are. And then on the blue line is 50 copies per mil. The red line is 200 copies per mil. And you'll see that each person has a different sort of y-axis based on what their levels are. But you can get a sense. I put this up here just as a resource for people to see that there are some people who just hang out in these low levels despite having started there. Some people have a really nice response and then just do still hang out in these sort of low level viremia, or these numbers less than 50, which may sometimes cause concern and cause stress and anxiety, but is somewhat normal in this realm. And then the other thing I wanted to mention is that what about in people experiencing homelessness? There was a poster at CROI out of an urban homeless healthcare center in SF of long-acting ART was associated with improved viral suppression and twice as many clinical encounters. And this was in a retrospective chart review of 94 people with HIV. So I think that was very exciting that there was better viral suppression as compared to oral standard of care here in the gray, and then the blue or the dark navy is long-acting ART. And similarly, more touches, more encounters, both with the clinic, pharmacists, case managers, their mental health providers, et cetera. So that's super exciting. How do you implement this? It is difficult. And I'm going to just touch on a few things about implementation. And I don't want to sort of belabor that, but I want to recognize that implementation has been very hard for all of us and for everyone. And I think that is very unfortunate. The group in San Francisco did an implementation. They shared in a paper about implementation strategies to sort of maximize Cabril, especially in people with viremia. And here they have this sort of image talking about people who are suppressed and engaged in care and for whom it may improve the quality of life, but their trade-off is increased volume of visits. What if you're suppressed and have suboptimal care engagement? It may be difficult to implement Cabril in clinic for them. And so they suggest could consider pharmacy implementation, maybe like an offsite pharmacy. And then what about for people who are not suppressed but engaged in care? That's a clear potential for high impact. So their recommendation, and I'm putting this out there for individuals who are hoping to sort of grow their programs, that maybe to start off here doing a small pilot, then they say you can then shift to the retained category, then here to the like people who are not suppressed but have suboptimal care engagement. And then they're saying like, wow, what happens if we can't even reach them? Then you may have to consider moving to out-of-clinic injections. With that in mind, more implementation and logistics. Implementation has been challenging, as I've mentioned. This is a paper that sort of looked at some of the issues, and I would say here it says 71% of people noted that the biggest clinic barrier to implementation was obtaining coverage for the cost of medication, new systems to track, schedule, and coordinate, new workflows and increased staffing, transportation support, et cetera. And so, again, I have no solutions. I'm just commenting on the barriers. And then here are the ranked barriers from an HIV/MA survey. And if you could focus on the light gray, which is Cabril, they also looked at injectable PrEP or injectable CAB. And here, prior authorization and appeals process are the biggest issue. Covered as a medical rather than pharmacy benefit is an issue. And so one of the facilitators, and I'll share this in another paper, and then also in this paper in CID, is that if possible to use a pharmacy benefit as opposed to a medical benefit is a facilitator to sort of implementing injectable Cabril. This is from Kat Kostopoulos. And again, these are not things that I want to sort of spend time on, but I just want to leave these here as potential resources for people when trying to sort of implement this in their clinics or start injectable programs. And so these are the steps to sort of go through when sort of thinking about this. And then this is, again, from the paper that Matt Hickey and the group sort of talked about those implementation strategies. And he has mapped this, and then Dr. Christopoulos made this image and shared it at ID Week, talking about the domains, barriers and facilitators, implementation strategies, and then actual strategies. And I just, again, wanted to leave this as a resource for people if it's at all helpful when you are sort of starting or trying to grow your programs. I certainly have found it helpful for us. And then another plug, Dr. Brian Wood interviews Dr. Benjamin Brock at the University of Mississippi about integrating injectable ART into their clinic there. It's 40 minutes and helpful for some. So injectables, or sort of the logistics of it, oral Cabril, here are the two components, comes from the pharmaceutical company directly to the patient as two separate pills. And then the IM components are, again, two separate injections, one of cabotegravir in one gluteus, one of rilpivirine in the other gluteus. And then here from, again, images from Dr. Brian Wood and Dr. Spock is schedules for every 1 month injectable Cabril, every 2 month injectable Cabril, and they have many other resources on the National HIV curriculum. Here, Dr. Spock has made these images about where to put the injection, that the preferred site is the ventrogluteal site. And again, a reminder that a longer needle may be required for people with a higher BMI, and an alternative injection site is the dorsogluteal site. That injection site reactions are a big deal, as I've sort of mentioned in some of the prior studies. And this group talked about they did a survey result of 181 healthcare providers administering injections in Atlas Flare and Atlas 2M to determine optimal injection techniques. And I'd like to just highlight that these are their survey results that the best that they found. And again, I think everyone has their own tips and tricks, and I think we should all be talking about their tips and tricks so that we can be sharing and learning from each other, and that the best pre-injection and injection procedure practices in this survey was pushing the IM injection at slow speed, bringing the medication to room temperature, and relaxing the gluteus muscle before injection. That the best post-injection practices were, again, these were all perceived from the healthcare professionals: over-the-counter pain relievers, returning to routine daily activities, resting or minimal activity, and light exercise, including maybe walking or doing some squats the day of to help sort of move the medication through the musculature. So here is, again, some data about how to minimize injection site reactions. What about alternate site injections? Data regarding non-gluteal IM injections are limited. We have early thigh pharmacokinetic data in persons who were previously on gluteal IM injections at steady state, temporarily switched to thigh IM injections for 16 weeks. That was promising, but is not recommended. And so you can't just have someone who comes in and says, oh, I have a filler, let me just start injecting this in the thigh. That's not the case, right? Because in this small study, people were on IM Cabril in the gluteus for up to, like, I think 3 years before they were just switched to the thigh for 16 weeks and then switched back to the gluteus. So what if the patient has fillers in their implants? The recommendation is to make a clinical assessment to see if the gluteal muscle can be accessed. And I think most of the time it can be. It may even require some ultrasound guidance. And then what about subcutaneous injections? Though the PK data appears similar to IM, patients had more side effects, such as pain and nodules with the subcutaneous infections or injections. And so at IES last summer, it was shared that this should not be or it is not being pursued. And then what about alternate injection locations, not just sites? So most people are receiving their Cabril in clinics, but some people, and a lot of people can be also receiving them at infusion centers. There was one study that showed that of 44 people with HIV receiving Cabril in an infusion center, none had confirmed virologic failure. That is in contrast to an experience from a Chicago HIV clinic, where a clinic of 75 people on Cabril, 10 were receiving their injections at an infusion center, and 2 of the 3 overall confirmed virologic failures occurred amongst people who were receiving that infusion center. So that had a virologic failure rate of 20%, whereas the 1 out of 65 in their other clinic had a virologic failure more akin to what we've normally seen, which is 1%. So that is something cautionary. What about the field? At Ward 86, of 9 patients who received out-of-clinic injections, none had virologic failure. And here is a table from their supplement of where those out-of-clinic injections were. And then what about home? There was one paper in CID published of 33 people in South Carolina where at-home injections by a healthcare professional were efficacious. So somebody went to their home and did it there, but it was a healthcare professional doing it. So I think, again, in the next decade, we'll see and we'll hear more about this. And then what about stopping Cabril? In 2 clinics, in Ward 86 and the Owen Clinic in San Diego, 16 to 20% of persons stopped injectables. The reasons varied, but pain and injection site reactions and logistical difficulties were main drivers of discontinuation. And if stopping Cabril, recall the very long pharmacokinetic tail of CAB. And this is one quote from Dr. Christopoulos's paper about someone who didn't like being on injectables. And it's not for everyone, and it's not forever. So this person said, I felt lost. When I'm on the shot, it's like basically no one cares anymore because I wasn't being seen by a doctor anymore, wasn't getting my blood drawn or anything. It just, things didn't feel right. So again, nuanced decision-making, shared decision-making, really making sure that we're thinking about this for the individual patient. Here is a resource for you all about managing dose interruptions. And let's finish off very quickly with lenacapavir. I told you all that I was going to sort of not do lenacapavir a lot of service, but we'll just finish it off very quickly anyway. So as background, lenacapavir is a capsid inhibitor administered subcutaneously every 6 months that was FDA approved in December 2022 for MDR HIV, informed mostly by the Capella study. And the Capella 156-week data showed that len, when combined with an optimized background regimen, led to high and sustained viral suppression in heavily treatment-experienced people with HIV. And the other thing that I sort of realized in doing this presentation is that len has many, many drug interactions, including with other ARTs. So when using lenacapavir, please take a look at that. There's an oral lenacapavir load followed by subcutaneous len given every 6 months. And there's 2 different ways to do the load. Here is just an image about sort of how it's dosed subcutaneously. This is option 1 for the oral load or for the loading. It's 2 days. Day 1, you take 2 pills, get the shots. And then day 2, you take 2 more pills. And followed by maintenance. Again, these images are from David Spock. And then here is the other option, which personally I would do option 1, which is, and this one is the same thing as option 1, but then another day 8 pill, and then you later get your shot. And so this might be perhaps for people who have a history of many drug allergies or drug intolerances who just want to try out the medication first before getting the shot. And then again, here's the maintenance every 6 months, which is very cool. As we all know, len is also used in or has been studied in PrEP, and hopefully FDA approval for it will be soon. 2 more slides on len. Side effects and nodules are very common. So in the Capella and Calibrate studies, injection site reactions ranged in people from 46 to 63% and 42 to 52%. What's interesting is that, you might say like, oh, the first one's the worst and then it gets better, but really in Capella and Calibrate, some people had it actually the worst the second dose and then better the third dose. So it's really kind of can be variable. And then there was another paper or poster that looked at some of the median duration of the days of these injection site reactions. And so I wanted to share this for people when you're counseling patients, that some of the swelling, erythema, pain lasts on the order of days, where the nodules and indurations can last on the order of months to years. And as you can see here with this interquartile range, we had some people who, that's like almost 2 years of a nodule. And here's an image, and you can't really, and this is from their poster, you can't really tell. It doesn't look like there's anything there, but underneath there's a nodule. And then some of those nodules that were present greater than 6 months, they actually biopsied, and they were just mostly just like granulomatous and fibrosis reactions to the medication. And again, this nodule is to be expected. It's really a depot of medication. And so it's, again, to be expected. So if you're having patients experience this, I wanted to sort of highlight this poster as a potential resource in your counseling. And then the sort of way in which I feel like I'm using Cabril the most is paired with lenacapavir, or sorry, not most, the where I'm using lenacapavir the most is paired with Cabril for MDR HIV. And we have sort of 2 studies that I have found very helpful. One is a case series of 34 patients from 4 clinics using off-label len and Cabril. And they demonstrated 94% viral suppression. They also called for more trials combining the 2. So or combining the 3, and so hopefully that will come. And then Dr. Benjamin Brock shared 9 patients in Mississippi who were prescribed len and Q8-week Cabril, and all achieved viral suppression. Here from their poster is 9 of their patients, what their rilpivirine scores were, and the fact that they just included Cabril and len for these people, and they all did well. So again, that was the quickest of lenacapavir sort of talks. I wanted to acknowledge our amazing clinical pharmacists, Dr. G. Lee, Bob Loffelbein, Meredith Potocnik, and Rupali Jain for sort of discussions and the care of our patients. Doctors Raka Kumbhakar and Trisha Danareddy, who are the Injectables review team with me, and we talk about this stuff all the time, and Doctors David Spock and Dr. Brian Wood for some of these slides. So I don't think I've left much time, but I'm happy to answer anything if left. Oh, and Dave Hatchie asks, if not covered, can you please comment on the changes in weight associated with Cabril? Dave, I'm curious what your experience has been, but we were just talking about this yesterday, and I think it was yesterday, but it seems as though, like, some patients have had some weight gain, some marginal weight gain, but I haven't really seen this huge amount of weight gain like I have, for example, with Big TAF FTC. And then I have had some patients who've had it be weight neutral. And then the one thing I can say is that nobody has like lost weight on Cabril. And it's 9. And I'm sorry that I talked so much about injectables.
No, this was excellent and comprehensive. Thank you so much, Dr. Budak. I know you're very passionate about this and the data and moving the needle on being able to access for patients being able to access this therapy. I think it's been much slower moving than I think a lot of people might have anticipated when these first came out. And it's really important to think about that kind of pathway and all the potential logistical barriers and have a plan for addressing those as you're ramping up the program. And so I think this is really excellent practical talk, but also reviews the data. And Dr. Budak is an excellent source if you're thinking about starting a program or expanding a program in your clinics. I know that we're out of time, but I'm sure Dr. Budak would be happy to answer any questions. Fine. Thank you all oh, there's one more thing. Oh, I have a patient with BMI greater than 40 who was recommended to get Q1 month injections of Capril. Can you comment on practice experience for high BMI?
Hi, Adrian. So yes, typically, I think when someone has a BMI 30 to 40, we feel comfortable doing Q2 month or Q8 week injections. Given that we just don't have data on the like class 3 obesity with the BMI greater than 40, I think we're just a little bit nervous about that. And so for that person, or for any individual greater than 40, we would prefer that they do Q month. Again, this is shared decision making, but that's the recommendation. And again, it's just that we just don't have much data on people with a BMI greater than 40. And again, with some of those things where we know people can fail, even with perfect adherence. And if this is a person who was previously on oral standard of care and doing well, we kind of were weighing the risks and benefits where we're saying like, hey, like we just really don't want you to fail. So we're recommending Q4 weeks. We're also oftentimes might recommend somebody does an oral lead-in just to make sure that we get really high concentrations, and then we keep that. And then I think as we get more data, we change our practice. We have done that multiple times already. And so every time there's anything about a high BMI, we sort of take a peek at that. But yeah, that's the reasoning for that, Adrian, and that in that person, it's just that we don't want them to fail. And because we don't have that much information about that higher BMI category, we wanted to be conservative and just play it safe for now.
Thank you. Thank you all so much and have a wonderful day. You're going to be getting some announcement about the summer ACCs shortly from Victor. And again, have a great day. Thanks.